Good morning and welcome to the Brown Heart Podcast, our second in this series. I'm Nirmal Joshi and next to me is Dr. Renu Joshi. And we have our guest speaker for today, Dr. Priyanka Satish. It is a pleasure having all of you join us. And our intent is to have a presentation for approximately half an hour, followed by an open question and answer session, for which the best way to input your questions is in the chat box on YouTube Live. So that is the intent. That's the purpose for this afternoon. We're delighted that you could join us. Checking.
Priyanka, can you hear us?
I can hear you, okay.
Yeah, I think we're good. I don't know what's happening. Are we good now?
No.
Can you go there and check with him? Okay, all right, we're good. All right, sorry for that short delay there. We're good now. We are having all the technical things are in place. So we will go ahead and get started. It's a pleasure to introduce you to the speaker for this morning, Dr. Priyanka Satish. Priyanka is the director and the director for cardiovascular prevention at Ascension Texas Cardiovascular. She also serves as an assistant professor at the Dell Medical School at the University of Texas at Austin. And perhaps equally importantly, Priyanka and us worked very closely together with the Brown Heart, with the documentary. Priyanka was one of three content experts who served on the on our advisory panel, expert panel for our content for Brown Heart documentary. We worked very closely together, and all of the principles that we have had the privilege of sharing with you with the Brown Heart documentary, Priyanka is very closely aligned with. So with that, I'm going to go ahead and let Priyanka take it from here, and we'll get started. Shut the door.
Dr. Joshi, thank you for that kind introduction. It's truly an honor to be here, and I'm so grateful for the opportunity. I'm also glad that we have so many people tuning in to listen to this because this is important. I'm a cardiologist. I see varied forms of heart disease every day in my practice, so this is very close to my heart. I see all the different presentations of heart disease. For some people, it's a minor stay in the hospital. For other people, it's a lifetime disease. For other people, it's death. So this is something
I heard you.
that's
Hey Priyanka, can you speak a little bit louder and maybe get a little closer to the microphone so that it seems like the voice is just a tad bit on the lower side?
Is this better?
Yeah, just do the best you can and we'll keep going then.
Okay, perfect. So we'll talk today about what are some preventive tests that can tell you that you need to start paying attention to your heart health. And this is important because if we catch these things early, we can actually prevent heart disease and its varied manifestations. So you will move the slides for me, Dr. Joshi, so if you go to the next slide. I want to start with some disclosures. These opinions are my own, and this presentation is purely educational.
Once again, Priyanka, sorry for the interruption. I think our microphone volume remains somewhat low. So if you can get closer to wherever the microphone is, if you're using the regular microphone, you might want to come a tad closer.
Is this increase from here?
Can you increase from here?
Is that better?
Yeah, we will not be able to live check that, but do the best you can, and we'll provide you feedback in just a minute. Sorry.
Okay, great. So we are just going over some disclosures. This is purely educational, of course. I'm going to check if this sounds all right so far.
Yeah, I think it got a little better, but we will continue to do the best we can. That's the main thing on the chat line, that the volume is pretty low on your end. So just speak up the best you can and get closer to wherever the microphone is.
Yeah, the microphone's actually pretty close to me. Um, is this any better?
Just bear with us, we'll find out.
Okay.
No, we're still struggling with the your end. Let me just double check on the collab cam. No, we are highest on the volume on this end.
And we're back to just regular microphone, and I'm actually pretty close to it. Is that still a problem?
Want to speak up one time?
Yeah. How's this sound?
Okay, it's a little better. So we are going to try to do the best we can. Just again, get close and speak up as loud as you can. That'll be great.
All right. So we can move forward then?
Yes, please.
Okay. All right. I'm as close to the microphone as possible. We are going to talk about atherosclerosis. That is the buildup of fats, cholesterol in the artery wall, and we call that plaque. So plaque here in the image, if you can point to it, is what's highlighted in yellow, and it's the fatty stuff that lines the arteries of the heart. Still hear me okay?
Yes.
Beautiful. So when this plaque happens, it can progress slowly, and if it does that, it will start narrowing the blood flow in the artery, and you start getting symptoms like chest pain. So if you go to the red circle above you, that is a narrowed artery. There is still some blood flow, but it's narrowed, so there's not a lot of blood flow, and you start having symptoms. On the other hand, if the plaque ruptures, it will completely shut off flow in the artery. Now, what that will do is cause a heart attack. So that's the blue circle, where you have no flow at all to a region of the heart because the artery completely shut off. Plaque buildup is a silent process. So you may have symptoms, you may not have symptoms at all, right up until a heart attack. So that's what makes this a little scary. Still audible so far?
Yeah, it still remains low, but is audible. So there are still complaints, but people are saying it's a little bit better. But we'll see how that goes. I might even get the source of the, this microphone itself closer to that. Let me see if that works better.
Okay. Should I try something else real quick?
No, let's try this. Let's try this now.
Okay. There's a bit of an echo. I don't know if people can hear that.
Okay.
It's good now. Keep going.
Okay, keep going, Priyanka. It's much better.
Beautiful. Okay, so next slide. So we've heard all of these stories of young Indians dropping dead. People are healthy, but they're dropping dead anyway. And there's lots of theories as to why this is happening. So some people mention genetics, some people think it's a lifestyle. And there's a big misconception out there that there's nothing we can do about this. This is in our genes, this is our faith. And I'm here to tell you that that's not true. Go to the next slide. So if you catch heart disease early, you can breathe it. Next slide, please. So let's talk about what we mean when we talk about your risk for heart disease. So when we're looking at cardiovascular risk, we're trying to take a group of people and try and see who is going to have disease and who is not going to be having any disease and is going to be okay. And we have lots of risk factors, things that we've studied that have shown to have an increased risk for heart disease. So some of them are highlighted in dark pink here. Those are things that we don't have any control over. So our age, our sex, our ethnicity, our genetics, our family history, and something called lipoprotein A, which we'll come to later. But if you look at the rest of the circle, all of it is within our control. So your cholesterol, blood pressure, sugar, what you eat, how much you move, your BMI, tobacco use, those are all levers that we can pull to make a difference in your heart disease risk. Next slide. I want to spend a little time on this slide because this is something that's not very well known. So there are certain conditions that if you have them, that raises your risk for heart disease. And it's kind of a red flag that, hey, there may be something going on in your body that is going to increase your future risk of heart disease, even if you don't have any problems right now. So the first one is women with pregnancy complications, such as preeclampsia, gestational diabetes. They are at an increased future risk for heart disease. Similarly, people with chronic kidney disease are at an increased risk for heart disease. Fatty liver, another condition, very common, and often people will say, oh, it's just a little bit of fat in the liver, it's not a big deal. No, it is kind of a big deal because of what it tells you, that you may have something underlying that's going wrong, and you have to start paying attention to it. Finally, people with inflammatory disorders, such as rheumatoid arthritis or inflammatory bowel disease, like Crohn's or ulcerative colitis, they are also at an increased risk for heart disease. Next slide. Before we talk about what tests are typically recommended for cardiovascular screening, let's talk about what is metabolic syndrome. Metabolic syndrome is a cluster risk factor that has insulin resistance as an underlying problem. So that is a cluster of abdominal obesity, high triglycerides, low HDL levels, so abnormalities in the cholesterol panel, mildly elevated sugars, elevated blood pressure. Those together tell us that there is something going on with the metabolism inside your body. So what tests do we recommend for understanding your metabolic and your cardiovascular risk? So in those less than 30 years old, we recommend a cholesterol or a lipid panel, your blood pressure check. We recommend a sugar test or an HbA1c test, which is for diabetes. And in people with metabolic syndrome, we consider fatty liver screening with at least a blood test. Next slide. Now, in people over 30 years, all of the above will apply, but add a consideration to screen for heart disease, especially in those who have a premature history of premature heart disease in their family members. So young family members developing heart disease or dying from heart disease, you can consider screening even as early as in your 30s. Above 40 is when it's recommended in global guidelines. The other thing I'll say is, if you don't check for these things, you have absolutely no way of knowing if you have them. Just because you feel okay, you're able to do everything you want on a daily basis, you exercise without any problems, it doesn't matter. You can still have these issues. And some of that is genetic, some of that is lifestyle, right? Air pollution can play a role. So really the only way to find out what is going on is by taking a look. Next slide. So let's talk about the lipid panel. Now this is simply known as your cholesterol test. And in patients with metabolic syndrome, we see certain very classic changes in your lipid panel. So that includes a high LDL level, high triglyceride level, low HDL level, and the HDL that exists does not work very well. Now, when you get your lipid panel, the first number that you see is actually your total cholesterol level. Now, notice I haven't put that on the slide because I want you to pay attention not to that total number, but to the LDL number or the LDL-C level, because your risk is determined by your LDL level. And the second thing I want you to pay attention to is your apolipoprotein B level or your ApoB level. I'm going to pause here and see if you guys can still hear me. Okay, we can move on to the next slide. So this one is a little bit into the nitty-gritty of what these different tests mean. So if you can bear with me, and I'm going to have you point to some things. So a lipoprotein is an individual particle that has the protein, cholesterol, and fats, and it transports them throughout the body. So every circular structure you see in the image is an individual lipoprotein. Now, LDL is a subclass of the lipoprotein, and it's called a low-density lipoprotein. So all of these little circles you see in the picture are LDL particles. Now, LDL-C or LDL cholesterol level, that is the number you're seeing on your blood test report. What that refers to is the mass of cholesterol in all of these particles. So that is the amount of blue in this image. So all of the blue added up together gives you your total LDL cholesterol level. Now, what is ApoB or apolipoprotein B? This is a separate blood test that you're going to get. It's not on your routine lipid panel, so you have to ask for it separately. But what it is a measure of the number of LDL particles. So we're going to look at two pictures, one on the left and one on the right. The left has 8 particles. The right has 12 particles. So the ApoB is going to be higher on the right. Whereas the amount of blue in both of these images might be the same. So the LDL level on the lipid panel might still be the same, but the ApoB is going to be higher on the right side image. Why does all this matter? In patients with metabolic syndrome, we tend to have what's called discordantly high ApoB levels for any given LDL level. So you can have a completely normal looking LDL level, but your ApoB may be high. And it turns out if that happens, you are still at an increased risk for heart disease. So the more particles you have, or the higher ApoB you have, the higher your cardiovascular risk is. So that was a little bit of a deep dive, but the big picture version of it is pay attention to the LDL level on your lipid panel. And the second thing if you have metabolic syndrome, also ask for an apolipoprotein B. Now remember, the test is apolipoprotein B, not the ApoB to A ratio. They're two separate tests. The test you want is just the ApoB level. I think we can move on to the next slide. Okay, so we talked about lipoprotein A being a genetic marker for your cardiovascular risk. Move this a little like this. Okay, hopefully it works.
I'm going to. Priyanka, give it a shot now.
Okay, it got better. So this is a genetic marker. It's similar to an LDL particle, but it is genetically mediated. So it's not really influenced by lifestyle. We recommend testing one time to see if you have an elevated lipoprotein A level. This is important because it is associated with premature heart disease. And so in families where multiple family members have heart disease in their 40s and 50s, this is sometimes a big player. Now, most Western organizations recognize over 50 milligram per deciliter is elevated. However, there's some data that in Indians, even greater than 20 milligram per deciliter might be associated with an increased risk. So this is a test we recommend doing once just to know if you have that elevated genetic risk. Now, we don't have treatments for lipoprotein A as of today specifically. However, we still recommend testing because if you have this, then we know we have to be aggressive with your other risk factors in terms of prevention. Next slide. So that was everything about cholesterol. Let's talk about blood pressure. Blood pressure is one of the largest risk factors globally for heart disease. And it turns out, in general, across the world, we don't do a very good job of getting blood pressure under control. And I've often heard people say things like, oh, my blood pressure is just a little bit elevated. It's not a big deal. It's just sort of in the yellow zone. It's only slightly red. It's not that bad. And I want to point you to this graph, and hopefully you guys can see. There's a blue line and there's a yellow line, and then a red line, I'm sorry. And the red line is your risk for having a heart attack if you have stage 1 hypertension. So if your blood pressure is over 130 over 80, that's called stage 1 hypertension. And even that is associated with a much higher risk for heart attacks compared to the blue line, which is if your blood pressure was normal. So this is to tell you that we don't recommend ignoring mildly elevated blood pressures because they increase your risk for heart attack. And there's similar data for strokes. The risk for strokes almost starts at even 120. So just things that are important to know. Next slide. So these are the latest guidelines on blood pressure treatment targets and who we treat. So if your blood pressure is in that stage 1 range, right, you're 130 over 80, we try to look, what is your cardiovascular risk? And do you have a bunch of those other risk factors that we talked about? Or do you not have any of those risk factors? You're relatively healthy, but you just have a mildly elevated blood pressure. So if you're low risk, blood pressure is 130 over 80, we have some time to try lifestyle changes alone. So we'll recommend a healthy diet, MASH diet, lots of fruits and vegetables, cutting out the sodium, not a lot of processed food. And then we'll see what happens to your blood pressure. And if it comes down, then you're good. If it doesn't come down, then we still will recommend treatment. because we don't want your organs to develop hypertensive damage. So we'll still recommend treatment. Now, if your blood pressure is the same over 130/80, but you're high risk with diabetes, your chronic kidney disease, or you've already been diagnosed with heart disease, then we recommend upfront medication along with lifestyle. Similarly, in those whose blood pressure is over 140 or 90, we again recommend upfront medication in addition to lifestyle. And why do we do that? Because we don't want to expose your organs to that level of hypertensive damage, that blood pressure mediated damage to the vessels going to the heart, the kidney, the brain. We want to try and minimize that risk as much as possible. Now, that does not mean that lifestyle is not effective. You still need the lifestyle piece. And in fact, in my practice, I have patients who have really turned their lifestyle around, and then I can take off their medicines if their blood pressure comes down. What we need to do is to check your blood pressure and make sure it's under control with or without medications. So next slide. Okay, moving on to visceral adiposity and diabetes. So visceral adiposity refers to a pot belly, abdominal obesity. It's the fat in your abdomen and the fat around your organs, and it's a problem. It's a big problem. The thing with South Asians, unfortunately, is that we tend to predominantly have a visceral adiposity type. You don't need to be obese to have this problem. You can be just lean with a little bit of a pot belly, and you can have visceral adiposity. This is important, and that is why multiple international guidelines recommend that a healthy BMI for South Asians is under 23, not even 25, but under 23. And at any given BMI, we unfortunately tend to have more fat deposition in all the wrong places. We call that the thin fat phenotype. Now, all these guidelines recommend that you screen for diabetes if your BMI is over 23 kilograms per meter square. And this is for young adults. As you grow older, everybody gets diabetes screening. Next slide. So how do we screen for diabetes? There's two tests. HbA1c is a pretty simple test to do. It looks for your 3-month average of your blood glucose levels, and it gives you a number. You want to be less than 5.6 if possible, and lower is better, honestly. The other test you can do is a fasting glucose, which also gives you some sense of what happens to your sugar levels early in the morning when you're fasting. And then some people, we recommend a postprandial glucose, usually 2 hours postprandial, to see what your blood glucose response to a diet is. And we recommend this screening in really all adults with risk factors. And we recommend periodic screening, even annually. Sometimes we do it every 3 to 6 months, depending on how abnormal it is. Now, the important thing to note is if you have this, your lifestyle changes can be very, very powerful in helping overcome some of this risk. So lifestyle can play a big role here. Okay, next slide. Finally, let's spend some time talking about screening for heart disease. We said if you are over the age of 30 or really over the age of 40, you can consider getting a screening test. The test is called a coronary artery calcium score. Now, what this is a CT scan. It's very low radiation. You don't get any IVs. You don't need anything in your arm to get in. There's no contrast involved. It's literally a 5-minute test. But what it tells us is if you have plaque, the fatty stuff, we can see that on the arteries. So if you look at where the red circle is highlighted, that is a picture of the heart. And Dr. Shed, if you want to point to it, where the red circle on the CT images, that is a picture of an artery of the heart, and all the white stuff in there, inside that artery, that's all plaque. So this person has a lot of plaque in their arteries, and that's a problem. Next slide. So who should get this
test. So first thing I'll say is, you should only get this test if you're asymptomatic. The test is not recommended for workup of symptoms such as chest pain. We recommend it people who have a borderline cardiovascular risk, who are on the fence, you maybe have some family history, or you have a history of preeclampsia, but everything else looks really good, and we're trying to decide if we want to put you on medications or not. This is a good test to determine if what your actual risk is. It's personalized, it accounts for everything going on and specific for you. Similarly, like I said, if you have some cancers or family history, you can get it. We don't recommend this test if you already have heart disease, you have a stent, you've had a heart attack, you've had bypass surgery. We already know you have heart disease. We don't need to screen you for heart disease, right? Or if the test will not change management, you're already on medications, your LDL is under control, your blood pressure is less than 120 already, there may not be too much to do once we get this test. Next slide. So this is a busy slide, but I thought this was interesting to show you guys. We now have South Asian specific data on coronary artery calcium scores and percentile by age, even for South Asians. We didn't used to have this. We used to extrapolate from other ethnicities, and now we have South Asian specific data, thanks to all the research that's been going on in this space. So if you go to the next slide, I just want a little bit more. I want to show you an example. So if we take a 39-year-old male, and I'm sorry if you can't see it very well, but if you take a 39-year-old male with a score of 20, that puts you on that green line, right? And that is the 95th percentile curve for age and sex. So you have a calcium score of 20, which the score goes from 0 to as high as anything, like it can go to 4,000. So 20 is actually not that much if you think about it. But for a 39-year-old male, 95% of people of your age will have a lower score than you. So in a 39-year-old male, even a score of 20 is a problem. So don't let people tell you, oh, it's mild, it's not a big deal. If you're a high percentile for age, you're on that trajectory to develop like severe heart disease. Okay, next slide. So the Lipid Association of India recognizes this, and that's why they have this algorithm where they give you what to do if you have different calcium scores. So if your calcium score is 0, that's great. You don't have calcified plaque. You still need to be healthy and do everything else. If your calcium score is in the mild range, we still care about what percentile for age you are. So if you are in that red box where you're greater than 75 percentile, go to the yellow. Yeah, there you go. So if you're in that red box where you're in the greater than 75 percentile for age, that still puts you at a very high risk. Similarly, as your calcium score goes up, that is a sign of increased risk. So over 100 or over 300, those are signs of high risk and extreme risk by the Indian guidelines. And why does this matter? If you go to the next slide. This matters because we decide on preventive medication therapy depending on your risk. So if you're low or moderate risk, we'll tell you keep your LDL less than 100 and keep your ApoB less than 90. So everybody who's walking around with an LDL of 140, 150, that's not normal. You want to try and bring it down to less than 100. That doesn't necessarily mean you need medication therapy. If you're low risk, sometimes we'll even try it, like diet changes depending on how much you have to go. Things like weight loss can help. Living a healthy lifestyle, cutting out the saturated fat. All of those can bring your LDL down, and that can help lower your cardiovascular risk. In those who are high risk, we recommend an LDL less than 70, an ApoB less than 80. And if you're extreme risk, the Indian guideline recommend even going to an LDL as low as 30. So lower is better. And if you are at a very high risk, getting that LDL as low as possible is better. There's a lot of data around how low LDL can prevent the progression of coronary calcification. Okay, next slide. All right, I want to spend a couple minutes talking about what are some common myths that we see. I often get asked, okay, my score is positive. I got a positive test. I have all this white stuff on my scan. Do I need a stent? No, if you don't have symptoms, usually we don't put stents in people without symptoms outside of very specific situations. So most people don't need a stent. Next. If the second thing, like I see a lot, especially among my Indian patients, is, oh no, I've already had this. Like this has already happened. There's nothing I can do going forward. No, this is a preventive test. We're trying to catch this before it causes you any problems. So lifestyle and sometimes medication, even if you have this, can significantly reduce your chance of having a heart attack. That's why we're doing the test in the first place, because we now have a window to intervene. Next. This is the other thing. So if your calcium score is 0, especially if you're young, that doesn't mean that you'll never develop heart disease. Remember, most young people will have a calcium score of 0. That doesn't mean that the metabolic syndrome doesn't matter, the high LDL doesn't matter. You can still have a calcium score of 0 and develop heart disease. The healthy lifestyle still matters. And sometimes we'll actually repeat the test in a few years if it's 0, just to see if it's changed. Okay, next slide. So those of you that watched the Brown Heart documentary, this will be familiar. This is what we call the heart health cockpit, where we're talking about your blood pressure, your sugars, normal values for these, your body mass index, the waist circumference, that's a slightly better marker of abdominal obesity compared to body mass index. Your cholesterol levels, see how the LDL here, the goal there is less than 70. Your ApoB is less than 90, and ideally you'd like to have a calcium score of 0. And that is something that is achievable if you start early enough by keeping your risk factor under control. Now note that if you have a positive calcium score and it's very high, the chance of going to 0 is not very great. Like once you have that calcification, you kind of have it. But you can still do a lot of things to prevent it from ever causing you any problems. So you can prevent heart attacks, you can prevent strokes. Next. This is a plug for those of you living in the US. There are many centers of excellence for South Asian cardiovascular health run by people that are interested in this space and are aware of the increased risk faced by South Asians. So to the left, I have a slide that was borrowed from the South Asian Heart Center in Mountain California, where they do a comprehensive risk assessment. Similarly, there are sites in Dallas, there are sites in Boston, we're in Austin. There are also research studies that if you are interested, I would encourage you being a part of, where Masala studied our health study. And the paper I have up top on the top right corner, that has a comprehensive list of cardiometabolic centers focusing on South Asian health. These are just a few of them. There are many more as well. With that, I think we'll stop and we'll leave some time for questions. Thank you.
Thank you, Priyanka. Thanks a lot for that wonderful, very, very comprehensive presentation. It was very easily understandable and went a very long way in clarifying several issues. So sorry to our audience for the somewhat erratic sound quality, which we had little control on along the way. It seemed to be working prior, but we will, what we will try to do is I will request Priyanka later on, maybe we are able to record some parts of it if it did not come through again, so that the lasting, kind of memorialization of the presentation on YouTube and our other sites, and for all of those who have joined and others, we will have a very high quality presentation as well, purely from a technical standpoint. I personally enjoyed the presentation immensely. I'm going to go to the more regular, give me 1 second. Okay, so there we go. That will look a little bit that will look a little bit better without the presentation, and it will make it a little easier. And so what we will do is we'll open it up for questions. Please feel free to type in on the chat box section of the talk. And I'm just looking here. One of the first questions in the chat box already is the BMI cutoff 23 for women as well?
Yeah, we don't really have gender-specific BMI cutoffs. We have gender-specific waist circumference cutoffs. And in general, waist circumference is recommended for people who don't have a high BMI to catch that increased visceral adiposity mediated risk.
That's great. And I think that's a good opportunity, Priyanka, while we are still waiting on some other questions. This is an opportunity to ask the question about, and I think you were beginning to answer that, which was in the context of waist circumference. We talked about visceral obesity, for example. In the context of waist circumference, I think what you were just saying was that if your BMI is high, in a sense, the waist circumference wouldn't matter. By definition, you are overweight and with all its attendant risks. In people who have normal BMIs, meaning in South Asians who have BMIs hovering right around 23 or less, you could still have visceral obesity or increased visceral fat, which is why the importance of doing a waist circumference. Can you clarify that a little bit more?
So BMI is a good test, but it's not a perfect test. So you can have bodybuilders, for example, who are very muscular, and their BMI will be high because they have a high muscle mass. On the other end, you can have someone who's doesn't have a high weight per se, but has abnormal body composition, and the BMI does not catch them. So the waist circumference is a good way to distinguish what your adiposity mediated risk is. There are also tests you can do, like a DEXA scan, or like there are scales you can stand on that will give you an actual body fat percent. So those are additional tests if you think you might be one of those outliers. But for most people, just a BMI and waist circumference are fine.
Yeah. And I think a question just came through, a specific situation. And I think it's good because it applies to several people, which is a woman who has a waist circumference, a BMI currently of 29. So by most definitions, that would be classified as being obese. And a waist circumference that says is good. I'm assuming it is less than, 80 centimeters and therefore there. Should she be concerned?
I think the body comp might give you a little bit more information in such situations. Is it a muscular problem, or do you still have increased fat, just not in the abdominal regions? So in general, higher adiposity levels are associated with worse cardiometabolic outcomes. So if that is still going on, even if it's not abdominal obesity, it matters, just not as much as abdominal obesity is.
Great. And Renu will ask.
So another question just came in, and I'm again sorry for people who had difficulty hearing you. I think we will be much more prepared next time. The question came in, while you can change Lp(a) since it is genetic, can you change the ApoB? And if so, how?
That is a great question. So ApoB is somewhat of a surrogate marker for your LDL itself, right? Like your LDL cholesterol often tracks with your ApoB levels. So a lot of things that we tell you for treatment of LDL lowers ApoB. So lifestyle changes like cutting out saturated fat, for example, right? Like cutting out red meat, butter, ghee, whole fat dairy, those things reduce your LDL, but also reduce your ApoB. The medicines that we prescribe sometimes, like statins those can reduce both LDL and ApoB.
So
the short answer is yes. It's not a non-modifiable risk factor.
okay, there is a question that says, please narrate lifestyle medications for various age groups with or without CVD. I'm not sure I'm understanding lifestyle medication, the word
maybe lifestyle and medication.
Yeah, I guess, yes. I'm assuming, yeah. So if you want to clarify and we'll come back to it. So yeah, whoever asked that, if you can please clarify that, Dr. Bhatt, if you can clarify that. And then while we are waiting, we can go to the next one, which is, why is advanced lipid panel, by the way, for those who don't know, that includes Lp(a) as well as ApoB. Why is advanced lipid panel not prescribed, given that it's the only panel that can isolate the LDL particle size that's more atherogenic? Wonderful question. I'll let Priyanka comment.
That is a great question. And there is a big push for ApoB to be included in routine testing. The other tests of LDL particles, particle size, personally, I find them less useful than just an ApoB. So your point is well taken that in a routine lipid panel does not capture the risk from all the ApoB particles. And you can somewhat circumvent that risk by just adding on an ApoB. And then you have to check an Lp(a).
Yeah, and I just add to that, which is that, and this is a question that comes up all the time as we talk about unique factors that affect South Asians and other high-risk groups, Hispanic groups, some other groups, and so on, is that people often ask us, well, why doesn't my doctor do this kind of routinely in me? And the short answer is that things are evolving as we speak. So there is a big information gap between what is already known in good research studies and change in medical practice among providers in general across the board. It is not unusual. And this is not criticism of providers. It's more, all of us are prone to that. By the time evidence comes out and we begin to make changes, sadly, sometimes it takes 8 to 10 to 11 years sometimes to make changes. We know that for a fact. So what ends up happening is, which is why this push for education and you being your best health advocate with your primary care provider, with your cardiologist, with others saying, here's the data. I want to get an advanced lipid panel with an Lp(a) and ApoB because I want to take better care of myself with your help, meaning the primary care provider or the cardiologist's help, will go a very long way. So the short answer is yes, it should be done. It's not done very commonly, other than very few providers. So you need to be advocating for yourselves more.
So I think Priyanka, Dr. Bhatt has clarified his question. It was more about lifestyle changes, which you should be making if you don't have cardiovascular disease. And I think that will be good to address for everyone.
That's perfect. Before we go to that, I wanted to add one point to what you just said, Dr. Yoshi, which is even in people who have known heart disease, so, people who have a stent, people who had bypass surgeries, right? We, unfortunately, as a society, just don't do a good enough job of keeping our LDLs to goal. Even if you look at less than 70, which is kind of a liberal goal, actually, the majority of patients are not at that goal. And there's many factors at play, but it unfortunately is the reality of how, where our management is. Coming to lifestyle. So there's a couple of things that really apply to everybody with or without heart disease. So like physical activity is one of those. So combination of aerobic activity and strength training is extremely important, especially in South Asians. Sarcopenia or low muscle mass is quite problematic. So combating that with strength training can be very, very helpful. Usual recommendations are at least 150 minutes per week of physical activity. If you're trying to achieve specific goals, that goes up. Like with weight loss, it's like 300 minutes per week. So it really depends on what you're trying to achieve. From a diet standpoint, the data is really around plant predominant diets. So that does not mean a vegetarian diet per se, but having a diet that's rich in whole food, plant-based dietary options. So what do I mean by that? Like vegetables, fruits, green leafy vegetables, right? Nuts, fiber-rich stuff like chia seeds and stuff. Those have all been associated with lower cardiovascular risk and really lower risk of a lot of other conditions like diabetes and even cancer, actually. Meanwhile, you want to try and avoid a lot of the processed stuff, the sweets, right? Those are all things that red meat has a lot of data that it increases your cardiovascular risk. So those are all things that increase your cardiovascular risk, and you want to try and minimize that as much as possible. And I get a lot of like questions on can I eat this versus that? The easy way to look at it is, are you meeting these big picture recommendations, right? If you are, then great. If you're not, focus on the big picture things, like can we increase our fruit intake? Can we substitute some of the refined stuff for more whole grain stuff? Like, so that those kind of things really go a long way. There's plenty of other things that actually matter. So sleep matters, right? 8 hours of sleep a day, which many of us don't get. Stress management is one of those things that's really underrated in terms of helping cardiovascular risk. So it's not all lifestyle. I mean, it's not all diet and exercise either. So all of these other things, community connections matter, air pollution matters. There was recently a trial where people put a HEPA filter in people's houses, and that lowered blood pressure like significantly. So air pollution is one of those things that matters. So whatever combination of these things you can do, that'll help your overall metabolic risk and really cardiovascular risk also.
Thank you. And I'll just add to that. I think one of the things maybe hidden in that question was age related, meaning if you're 30 versus 40 versus 50 versus 60 versus 70. And I think one thing that every time we get the opportunity to do, we always put a plug for it, that it is never too early and it's never too late, right? Meaning there is data after data after data that's similar to investing money. The sooner you invest, whether it be heart prevention or bone strengthening or muscle strengthening or brain agility, whichever ones of these you are trying to impact, the sooner you can start in age, the better. So if we are able to convince parents to take care of their children where childhood obesity is prevented, for example, there is a huge amount of data on that. And then when you're an adult, starting age 30, which is the hardest age to impact, right? That whole age group between, say, 25 to 40, we find is the hardest to impact because it's the age where we feel we are immortal. And it's the hardest one. So the point being, inherent in your question, I would strongly say that the earlier you can begin, the better. But for many of us, particularly in the Indian community, even if we begin it in our 50s and 60s, that's okay. What you can do, is still important at that time. And even building muscles, for example, which we generally lag behind many of our Western counterparts with sarcopenia, like you said, sarcopenia meaning lower muscle mass, the less amount of muscle. So if we fall, we can break our bones, for example. So all of those things I think are important, and age doesn't matter.
I think while there are a couple of questions on HDL and LDL, I think one of them I do want to take because that has not been addressed is, can you highlight the importance of high sensitive CRP and homocysteine levels in preventing cardiovascular disease?
Great. So hsCRP is a reflection of the systemic inflammation going on in the body. So in people who don't have autoimmune diseases, if your hsCRP is elevated, you might have a residual inflammation-mediated risk for heart disease, even if everything else is good. The question becomes really, what do we do about that? So things that we know and are pretty easy, like cutting out red meat, cutting out animal protein, can lower your HSCRP. Plant-predominant foods have been shown to lower your CRP levels. Statins have some effect on your HSCRP levels. Some of the other medicines also have a similar effect. Our community is a little bit divided on whether medications specifically to lower inflammation are worthwhile. In people without heart disease, what we call primary prevention space, probably not. In people with heart disease, it sometimes can be considered. That being said, if that exists, then it's kind of another sign that you need to work on a lot of your other risk factors in lifestyle. Homocysteine had a lot of interest as a cardiovascular risk factor, and it definitely is associated with heart disease. However, trials of folate supplementation to reduce homocysteine levels did not reduce heart disease risk. Now, these trials were all conducted in developed countries where folate deficiency is pretty low. So if we conduct this in a place with higher folate deficiency levels, will the results be different? We don't really know. Regardless, if you're getting a diet that's pretty wholesome with like greens and vegetables, the chance of you developing folate deficiency is pretty low. So really focus on your diet, and that should take care of a lot of these risk factors.
Yeah, I have a quick comment, and then we have one other thoughtful question up there. So the comment before I forget, and while we have our audience, is Priyanka mentioned the South Asian Heart Center in Mountain View, California, and the next webinar, the next podcast will be by them, and I think October 12th is I think what we are going for. Sunday, October 12th, same time, obviously, and we will. I'm really looking forward to that just as much as I was looking forward to today's, because that one is going to go into just the specifics of what health coaching can get you, right? Hand holding. Most of us, our problem is we take 3 steps forward and 2 backwards, myself included, everyone included. We're all human. So how do we get help in sustaining? Well, starting first of all, and then sustaining with the help of someone who is kind of who's a health coach, who's standing by with us. And I think it's wonderful. We've seen some amazing data come out of that, but I think I would love to have people hear about that process, which is extremely exciting to me. So please do mark your calendars. It's October 12th. Same setup, same everything. Certainly my hope is better sound. We'll figure that out between now and then, but do join us. And then I'll have Renu ask this question from the...
So there are 2 questions, Priyanka, for you. One is a low HDL along with a low LDL. What is the importance of that? And the other one is, can the LDL be misleading because the small dense LDL compound may be low or high?
Good question. We didn't really get into HDL very much. That was almost intentional. So the LDL count in your lipid panel is not a very good proxy of, I'm sorry, the HDL count, not the LDL count. The HDL count in your lipid panel is not a very good proxy of HDL function, which is actually what matters. Is how well is the HDL doing its job. If the HDL is not doing a great job, then that does increase your risk for problems. That being said, a low HDL can be a sign of metabolic syndrome if associated with other factors, like your triglycerides are high, you have abdominal obesity, right? A low HDL can be just a sign that something is going on from an insulin resistant metabolic syndrome standpoint. So I would look at it that way. That being said, your cardiovascular risk is predominantly driven by your LDL levels and your ApoB levels. So if your LDL level is low, that's a good thing. Can you guys still hear me?
Yeah.
Okay, your video cut out. Speaking of ApoB and LDL, yes, LDL levels can be misleading. So that was the picture that we talked about, where if you have 8 large particles versus 12 small particles, the LDL-C level on your lipid panel will still be the same for both of these scenarios. But your risk is higher if you have 12 small particles. So the ApoB captures that risk. That's why we recommend, if you think you might have metabolic syndrome or a discordance, tracking the ApoB level can give you a lot of extra information.
I think we are coming close to the time, and we will answer other questions in the chat in the Brown Heart as well. But there was one thing which I think it's important. They said, do these risks explain the apparent increase in sudden death in younger populations seen recently? Are we in the ascent phase of the actual cardiac pandemic? I think it's a very good question.
That is a very good question. Sudden cardiac death means your heart stopped, right? Cardiac arrest or sudden cardiac death means the heart stopped. And coronary artery disease or atherosclerosis, all the stuff we talked about today, is only one piece of that puzzle. So it's one cause of sudden cardiac death. A heart attack is only one of many causes of cardiac arrest. And while it is important and cardiovascular disease is rising in the young, there isn't enough data actually to know for sure what exactly is the cause of sudden cardiac death in young individuals. And it very well might be that it's coronary artery disease, but if you look at athlete populations worldwide, in younger adults, actually coronary artery disease is not the #1 cause of sudden cardiac death. So this is not to say that coronary artery disease does not matter or that young people cannot develop coronary artery disease and blockages, but we need more data actually on what causes sudden cardiac death. And then the pandemic of cardiovascular disease and coronary artery disease, it's a problem. It's the rates of obesity in children is rising. The rates of fatty liver in young adults is actually astonishing. And all of these are going to translate into increasing coronary artery disease or plaque-related, blockage-related disease in younger and younger individuals. So prevention at a society level is going to be extremely important.
With that, it's right around 12:30. It's a wonderful hour spent together. I will end with the primary notion that we have started all of these, the podcasts, everything, the Brown Heart documentary, is our absolute passionate assumption that upwards of 80% of this stuff can be prevented. You are responsible for that. We are responsible for that together as a community, as a person, as people, to change lifestyle. One step at a time, not get flustered if you fail, but continue to try. It's a work in evolution. It's a work in progress. Just like all human beings, we all live in glass houses. We all find it hard to change behavior, but we need to keep trying, and we need to passionately keep trying with the belief that we can prevent what we can prevent. And with that, I'll have Renu give the final word, and we'll start.
Yeah, so my final word is, like Priyanka said, go get yourself tested. Because if you don't know what's wrong with you, you're not going to be able to fix it. So get yourself checked for blood pressure, for diabetes, Lp(a), lipid panel, and CAC score, whatever you need to do to improve that lifestyle, that'll motivate you to change that lifestyle, do that.
Thank you very much, Priyanka, for giving us this time and a wonderful talk. You did an outstanding job, and we really, really, really appreciate it. Thank you so much, and everyone have a wonderful rest of your beautiful Sunday afternoon. It looks very good here out in the East Coast here. I don't know about the West and